Hello, this is Aaron, and we are going to be talking about cough in the early clinical experience. This follows on some of the other discussions about cough as a sort of physiologic principle, but we're going to do a little bit here in terms of just some of the questions that you might ask about cough. And for those of you who have already thought a little bit about clinical skills, there's a well-known mnemonic called PPQRST. PPQRST. So this is palliative. And this is provocative. Quality, or how somebody might experience the cough, whether it's severe or how it sounds, whether or not there's a radiation of the cough, which is less of an issue for us. Severity, timing, and then there are a few other questions that we're going to talk about, like associated symptoms, age, and we'll get to exam and a few other things like that. So for palliative, some of the questions you might ask are, is it related to sleep? So often coughs will get better with sleep, but sometimes they keep people awake. Do medicines make it better? And if so, which ones make it better? Or are there things that make it worse, like cold air? So sometimes in asthma, which can cause a cough, cold air would bring it on or make it worse. Same thing with exercise. That can be something that can make it worse, or talking. So that's one thing. In terms of the quality, there might be a particular sound. So we've heard people often talk about the croup sound, which is or a whoop in whooping cough. And there can be, I'm going to put paroxysmal here, and that's usually means that there are these fits of coughing that come together. Radiation doesn't really have too much to do with cough. Your cough can't go anywhere, although sometimes you'll get pain or discomfort that will. Severity, likewise, they can rate it from 1 to 10, or they can describe the things they can't do. And timing, we're going to talk about in a moment. And associated, this is an important group because you want to know whether or not they have any breathing issues that come with it. And the fancy word for shortness of breath in medicine is dyspnea. And you want to know absolutely whether or not tobacco is an issue, whether or not they might have a fever. So obviously that makes infection more likely. Some other things like nasal congestion, because stuff running down the back of your throat or a runny nose can lead to a cough. And you can tell I can't talk and spell at the same time. There are some medicines. So was this person on a blood pressure medicine called an ACE inhibitor? Those are the ones that end in pril. So that's a group of things. And it's important to know about age, because age has a big effect on the types of illnesses, right? So little kids get different illnesses, and adolescents get different illnesses than adults, and the kinds of exposures. So we would hope that a 5-year-old's not smoking, but secondhand smoke would be a big thing that a kid might be exposed to. It's true of adults also. Also, adults appear to be less likely to inhale small Legos, whereas little kids might do something like that. So if you had a cough due to a lodged Lego or other foreign body, sometimes that's more common in kids. There are a couple of other things we want to think about. So the vitals, so their blood pressure, somebody with a cough, there we go, vitals. Somebody with a cough and a high heart rate, they might be sicker, or a high respiratory rate, they also might be sicker. This would tend to lead you more toward things like pneumonia or maybe congestive heart failure that's worse. And we already sort of mentioned fever. And then you would do an exam, right? You would always do an exam. And there are a variety of things you might listen to, and we'll talk about that more in other places. And then there is the sputum. And this is sort of fun. So this sputum is the stuff that people cough up. And there are a bunch of different things you can say about sputum, but there are three types I'm going to talk about. So one is purulent. And purulent sputum is pus. Whoops, that should be an L. So if you just were to take your standard sputum, which might be sort of a whitish color, there's the whitish color, and then sputum, really you got to start adding in a little bit of, oh there we go, a little yellow and some green, just the right sort of amount of green. Sometimes it'll smell, and this might lead you more toward infection. Right? You might be more likely to think, well, infection is going on. Well, if we go back, you might have just clear, plain old white, either white or clear, and this might be mucoid. Whoops. Get rid of that. And this is mucoid. And we're going to talk about blood here in a moment, so I'll just write that while I have the right pen. Mucoid, this might be something like chronic bronchitis. Might look like that. And then blood. Well, there are several ways you can have blood. So one way would be sort of your regular sputum. Here's a sputum. And then just little streaks of blood. So, and the streaks, that could be from a whole bunch of things. Sometimes infections can cause that. But then you can also just have blood. This is where you got to be a little bit more worried about things like cancers and growths, and there are some other causes that cause, but this is called hemoptysis. All right, not very pretty, but that's what it is. So next time we're going to talk a little bit more about timing and the timeline, and we'll see you then.